So what I have to do is to discuss these abstracts. So please negate the panelists. There is a change in the name of the panelist. This is the order in which we will discuss, starting from real world to driver mutations, going to pneumonitis, proton therapy, and then role of concurrent versus sequential checkpoint inhibitors in stage 3 lung cancer. So one or two defaults are that yes, we are restricting our discussion to stage 3 lung cancer, and we presume that all these patients in the discussion will go for concurrent CTRT and then on some sort of IO or not IO. So this is that data, and I will request the house as well as the panelists to concentrate on 2 years and just remember these figures in mind. If you don't give Durvalumab, it is 25% PFS and 45% if you give Durvalumab. And please keep these things in mind. That will help us to sort out the discussion. And the other figure of 2 years, of course, we have the 5 years data. We are all aware that I'm not.
Are we done? Team 1?
Oh my God. No, we are not done yet. We are started yet. And second was 55 versus 66% is the 2-year probability of OS. Why I am suggesting these is because the studies and others we are discussing, we will be concentrating on 2 years, and many of the analysis don't have the 5-year data. So that is 25 versus 40 and 55 versus 66. So we can start with Shashank. Do you still wish to see real world evidence after Pacific? As Rajat mentioned, it is a wave or an ocean. If you have seen an ocean, do you still want to see the RWA, or you consider it as a wave and you still want to see RWE, that is real world evidence, as the ocean?
Yes, sir. I have to see the real world evidence.
Great. You want to see the real world evidence, and that was shown by Pacific R. Does it change your impression because you wanted to see the real world evidence? Does it change something? We have the 2-year data. Pacific R was 73 versus Pacific 66. That's why I told you to remember these words, these data sets. They will come again and again in the discussion. And the PFS, 2-year PFS is 52 versus 48. No, sorry, the 2-year PFS of the Pacific R, that is real world, is 50%. And it was 40% in the Pacific study. So does it change something after seeing real world evidence? Does it give you more confidence? Do you feel, because the numbers are more, the numbers are almost double of Pacific. The number there are 900 as compared to Pacific having 400. So yes, absolutely yes, double the number.
Yes, sir.
So does it give you more confidence in Durvalumab consolidation? And do you believe that in real world the patients will do actually better? Because in this data set, the real world patients are actually doing better. If you see, the 2-year overall survival is around 66%, which was similar to Pacific, but the 2-year PFS is 52%, which was around 45 in the Pacific.
Yes, sir. Actually, in the real world scenario, we come across various clinical situations which are taken ideal as in the trial settings. So in the real world scenario, which the data comes, I will be very much confident about following that.
Okay, anyone else? Vipul or Prahlad, does it makes a difference to you without real world, with real world?
Yeah, I think we should see the real data, sir, because...
so you are happy to see the real world evidence apart from the Pacific trial?
Yes. The Pacific trial itself has shown a good benefit, so it was a good drug and we were using it. But with the coming of the real world data, now we are more confident using it. So
okay, so we all believe in real world data. Then what to do with this PDL1? Now PDL1, if it is less than 1% versus more than 1%, there is almost a 10% difference, and this 10% difference is in absolute terms same what we have seen with Pacific. I mean, that's why I told you to remember the figure. There is a 10% difference at 2 years in the Pacific trial if you don't give Durva versus you give, and there is absolutely a 10% difference when your PDL1 is less than 1% and more than 1%. 2-year, or if you see 3-year overall survival is 54 versus 67. Below are the reference for you for Durvalumab. If your PDL1 status is less than 1% in Pacific, your hazard ratio is 1.36. I know the numbers are less. That means that you are maybe slightly harming by putting these patients on Durvalumab. And the PFS is still in favor, but if you can see, the confidence interval is easily crossing unity. And if you know, the EMA approval is for less than more than 1%. If there is a difference in the approvals, EMA still sticks to a 1% cutoff. And we believe in real world. So in Monday morning, more than 1%, will you prescribe PDL1 Durvalumab consolidation in a patient who is PDL1 negative?
It's difficult to take question.
No,
but
we
I
believe in
think,
real world. You all
yeah, we
three
do.
said that you believe in real world.
Yes,
You believe in real world. You believe in Pacific. Pacific is showing that PDL1 negative, it is not working. You believe in EMA approval. If you believe in this, then why we are not doing PDL1?
Yeah, it is important to do PDL1, and when the status is less than 1%, there is a caution to use Durvalumab as considering this real world data.
But that was also there in Pacific. See, when we don't discuss it because the company will never bring these points. They will never bring and show you these curves that PDL1 was less than 1% and hazard ratio is going to 1.36 and your PFS is crossing, the confidence interval is crossing unity. That will never be discussed in those forums. Anyone else from the panel or from the house, PDL1 negative, are we comfortable in giving? First from the panel and then from the house if there is a comment. PDL1 negative, Monday morning.
No, sir.
No, you will not give Durvalumab. Perfect. Yes, no? No Durvalumab. Anyone from the house, PDL1 negative? So the experts have a unanimous no. Anyone would like to contest and say yes? So the US FDA gives, I mean, we all believe that US is big. So US says that you give to everyone. And they also say that this was a post hoc analysis. And this was not the pre-stratified factor. There were only 3 pre-stratified factors: age, sex, and smoking history. These were the only 3 for Pacific. PDL1 was this is a post hoc analysis, and the US says that it was not accounted for. Anyone from the house, do we take it as unanimous no for a PDL1 negative Monday morning Durvalumab consolidation? No. So raise of hands we can do. How many will give PDL1 negative? Okay, so we have 5, 6 only. Okay. And can we see a raise of hands for those who will give, who will not give? Okay, so there are more people who will not give PDL1 negative. Perfect. And that goes with our experts also here. Coming to the next difficult part of my... Hi Navneet, your face was covered with mask. I could not identify you. Good.
That's fine. I'm still the same person with or without a mask. So the only caveat for this is what method you used for PDL1 expression, what method did the trial use, what method was used in the patient, and how accurate was the PDL1 testing interpretation, because PDL1 interpretation itself can be a challenge.
I do take these points, but my point was that this was more of a post hoc exploratory analysis. That was my point. But if we presume, I will put a question to you. Let us presume that we follow exactly what was done in the Pacific trial. We use a trained pathologist sees the antibody and exactly the same thing is done. Then
Which
are
antibody?
you comfortable that if it is PDL1 negative, you will
which
not
antibody?
use it? I mean, we have only SP263 and we don't have the... So I think this is Durvalumab. So we will have SP263 for us.
Correct.
So if everything is done as per the trial, PDL1 negative, you will not give.
In all likelihood, I would
You
not
only
use.
you have asked me the same question.
Yeah,
that
I will not use.
you will not use.
I
Perfect.
would be
Thanks.
more cautious in trying to rule out EGFR and ALK.
We will come
in
to
all
that.
this.
That is a separate scenario. We know that PDL1 and EGFR will work separately. So PDL1 negative, most of us will not give. Coming to the EGFR, we'll start with again Pacific trial. This is the again not a pre-stratified, but this is as per the forest plots. I will just magnify the forest plot for the house. So if you have EGFR positive, the patient number is less. So total number of patients EGFR positive were 17 and 8, which was 25, around 25, 26, which makes it around 5 or 6% in the complete data set. The hazard ratio is 0.85 for EGFR positive, and for EGFR negative it is 0.66. This is the overall survival. And for the PFS, of course, the numbers are less, but the confidence interval is very wide. It is 0.4 to 1.71. And this is what was presented, that the PFS will not make any the PFS will be worse if someone has driver mutation, irrespective. That was a surprise to me, that if you have a KRAS or a non-KRAS, your PFS will be as bad if you put them on Durvalumab. And of course, your PFS2 is better in non-KRAS, but not in KRAS, because you don't have a very good drug. And I presume that when this trial was conducted, maybe these patients were not subjected to sotorasib, or it was not available and not approved to be used in this setting and setup. Or in the later lines also, when the PFS2 happens or when they progress, we don't have that information in the paper that whether they were these all patients. For example, what I want to say is that if a EGFR positive patient progresses post CTRT, 100% in this era when this trial was conducted, they will go on some TKI. But that may not be the case for when we are interpreting these curves for the sotorasib or the KRAS G12C patients. And yes, overall survival is slightly better, though not significant. So this is the data which has been presented. There is some retrospective data set, and these are the above are all retrospective, very few numbers, 20, 30 in this slide. And if you see the 2-year PFS is again 25%, which is equivalent to the control arm of Pacific, which was 26% at 2 years. And if you see the overall survival is 80%, which is much better in EGFR positive populations. And they have around 30 to 40% chances of brain metastasis, and their distant metastasis rate is 80%. Whereas if you go to the Pacific trial, their 2-year overall survival is 66%, and their 2-year PFS is 45%. So this is what we have. And I will just show you one more slide, and then we will come to discussion. This is actually a print screen, and the slide credit goes to the person who has presented at ESMO Asia. There are around 200 patients who have gone on erlotinib versus cis-eto with radiation therapy. And if you can see, there is a phenomenal difference. Though the numbers are less, it is a phase 2 trial. If you give erlotinib with radiotherapy, and then erlotinib was continued, versus if you give cis-eto, you can easily see that the p-value is 0.001, and the hazard ratio is exactly or slightly better than ADAURA, which is 0.1. Of course, this is a phase 2. I do accept that. So this is we have, and there is no toxicity difference. So cut time short, I will come to the discussion. Tomorrow we have a stage 3 AB lung cancer. We will presume for the discussion that these are all unresectable driver mutation positive lung cancers. So you will consider NGS for all driver mutations, yes or no? Before putting the patients on Durvalumab, and when they are on CTRT, we have enough time.
Yes, sir.
Dipali, do you agree? Will you tell your medical oncologist that yes, please do NGS, then only we will decide, we start chemo radiation, and then we decide whether the patient goes on Durvalumab, yes or no? Do you need to have NGS as of today?
Yes.
Okay, agreed. Unanimous yes, no confusion. You will not do EGFR AL cross, you will do NGS. Okay. For squamous also? I know I'm extending it a bit too much. For squamous also, yes or no? Or EGFR AL cross for squamous? Be loud. They are not able to, I am not able to hear. How will the house hear?
NGS for squamous also, sir.
NGS of squamous also. That means you do NGS squamous for everyone in the metastatic settings also.
Yes.
Yes? No, yes? Yes. Okay. So NGS for everyone. Okay, great. Fine. No, I was asking because they said that they will do NGS even for squamous. Acha, okay. Maybe there is. No, that is a mutant NSCLC. I have typed it as M. It is a mutant NSCLC here. It is a mutant. That was my first default statement that we are discussing only stage 3. Second was that if you have a mutated EGFR positive or KRAS or ALK or ROS, I mean we know MET. Let us say KRAS versus non-KRAS. Will you give Durva consolidation, yes or no?
No, because it is not.
KRAS also no.
No.
Okay. Yes, no. KRAS, non-KRAS. Because we have done NGS, so we will have everything. We will have EGFR, ALK, ROS, MET, BRAF, everything in our hand. I mean, we'll have all that information now. Okay, you can have a comment here, please. If you want, you can ask a question to our experts and me also. Please tell. Yes or no?
KRAS we can give.
KRAS you will give Durvalumab. Okay.
Yes, sir. On KRAS, if the other driver mutations are negative and only KRAS,
I think that what Rajat also suggested, that in KRAS there was a benefit in the real world. Hai na? Rajat, you told that. Because
66 patients in May 2022, so that showed that the KRAS patients did better.
okay, because I was actually surprised to see that their PFS is absolutely, if you see the curves are going parallel, there is absolutely no difference. I mean, of course, this is one of the studies,
yeah,
but
so-
this is a large study data set.
So that was a different study, a European study.
Okay, so for KRAS, one of the experts would like to give, two of the experts would like to give, you would not like to give for KRAS Durvalumab consolidation. Okay. Any comments from the house for the KRAS? Anything, Vijay? KRAS, you would like to give Durvalumab consolidation? You will give Durvalumab consolidation. Okay. Thank you. Any difference to the mind of toxicity if you give in a mutation positive? These are all mutated NSCLC. This is mutated NSCLC. Any difference to the toxicity? Dipali? To your mind, do you feel that these patients in their lifetime will be going for some sort of EGFR therapy? You know that their PFS will be worse, and after the CTRT and Durvalumab consolidation, they will be going for TKI. And my worry is that when we have subjected them to IO, it is a well-known fact in the literature that if you have given Durvalumab, first of all, whether it benefits or not, we don't know. Apart from that, there is a problem that when you start TKI, maybe the patient progresses in a year or two, and if you put them on erlotinib or osimertinib, they will have good amount of toxicity.
Yes, definitely there will be slight increase in the immune-related side effects with all grades. So with Durvalumab, it will be increased.
Okay. So what do we do for EGFR mutated NSCLC Monday morning? Observe after CTRT Durvalumab for 1 year or osimertinib. If you don't have the LAURA trial, we all are not as lucky as TMH and RGCI. You don't have a trial, then what do you do tomorrow? Monday morning patient comes, CTRT started, CTRT finished, NGS report has come, it is EGFR positive. Yes, Dipali, first you. What will you say in MDT?
Sir, I will refer to my medical
Medical oncologist. We have 3 medical oncologists here, not even one. Tell. We can start from the left and right. Yes.
Not affordable for osimertinib observes.
No, patient is affordable for osimertinib. You don't worry. You have the guts to start, you start. Patient is affordable for osimertinib. Data is not yet out. We all know that LAURA is recruiting patients and you don't have access to clinical trial. So you will put them on osimertinib or observe or Durvalumab.
Observes.
Observe. Okay.
So, we can put on osimertinib as.
What will you do? Observe or osimertinib?
Osimertinib.
Till progression, 1 year, 2 years, 3 years. ADORA is 3 years, LAURA is 2 years. Till progression, patient is stage 3B, 3C, 3C. Patient is stage 3C. CTRT done.
Sir, I can follow the ADORA data and.
You will give for 3 years. Okay.
I'll discuss with the patient that this is still in the clinical trial, but still we can feel there will be a benefit, and with the doubt of benefit, the benefit of doubt, we can consider using osimertinib for
We don't know whether the benefit will be there or not, whether the benefit will be only PFS or OS. We are still banging our head for ADORA also, where the PFS, the hazard ratio standing between 0.1, 0.2, but still there is a debate whether the OS will come or not. So it is not that simple. So I feel that to my mind, observation may be the right point, but yes, putting osimertinib and then to give how many years is also not very clear to my mind, that whether to give it for 2 or 3 years. So fine, I think we may either, but that is one unanimous answer which can go to the house that they are not going on Durvalumab. KRAS are going, non-KRAS drivers, they are not going on Durvalumab. That is one message which we have done from the discussion. Now whether we observe them or put them on osimertinib, the experts are divided. Coming to this abstract, this was actually a bit difficult. I think we have already heard this is about grade 2 pneumonitis. I will make 1 or 2 comments and we go to discussion. These were those patients who were not having any significant pneumonitis and they were put on Durvalumab maintenance. That is first point. Second is, the previous speaker also did mention about this, that mostly what is happening in this graphs are those who have gone on Durvalumab and then they have suffered grade 2 or more. Grade 1 is asymptomatic and grade 2 pneumonitis is if they are having symptoms like cough, breathlessness, but not requiring oxygen. And if they require oxygen, it goes to grade 3. And if you see these curves, the dotted lines are those lines where the threshold for clinical relevance, that is more than 10% in this study, will exceed, and it is not exceeding either on the up or down of the graph. I'm just making it a bit simple so that we can go to the discussion. And then there were models which were applied for the and then there were statistics applied to it and seen that whether the model 1, model 2 and others benefit or not. And we know the Pacific study that the pneumonitis was significant, all grades 33%, but grade 3-4 was 3.4%. So we'll start with Dipali first. Dipali, how will you diagnose and manage a pneumonitis while the patient is on Durvalumab maintenance? And we presume that all these patients were okay, and then they have started on, they have finished CTRT, 1 month has gone by, and now we have started Durvalumab, and now we are sitting at 3 months, 6 months of Durvalumab. So how do you diagnose pneumonitis, and then how do you manage it?
So
Let us say
mainly-
it is a grade 2 pneumonitis. So diagnosis
mainly
and
the
management.
symptoms, and it's a diagnosis of exclusion only because all these patients were not having pneumonitis while on Durvalumab. So generally it occurs at 2.5 months. So we have to look after the symptoms as well as the imaging. And if it is diagnosed as a pneumonitis, we should go ahead with the steroids. So high dose steroids with tapering doses of prednisolone will help.
So mainly you will keep a low threshold on clinical symptoms and then a
Yes, because the continuation
imaging.
of Durvalumab will depend upon the grade of pneumonitis. So we have to check it early and treat it early.
Fine. I will come. Any other comments apart from diagnosis? So suppose someone is diagnosed with grade 2 pneumonitis. You will start steroids. Let us say it was a low dose steroid. Steroid has been tapered. Now it has come less than 10 mg. What next? Will you put them again on Durvalumab maintenance?
If patient is maintaining on less than 10 mg prednisolone and the symptoms resolve within 12 weeks, we can restart.
You would like to restart Durvalumab and continue that. Any other? You want to have a comment on diagnosis management? Any experience? Anything you want to make a comment? Dipali has said yes. Symptoms and CTs will be the key to it. You have to rule out infections. We have to see the baseline CTs. That's why we always say that don't do a PET CT and do a CT after 4, because that will be your one of the prime factors where you can compare post CTRT and then you compare it down the lane 3-6 months. So if someone has a grade 2 pneumonitis, will you re-challenge the Durvalumab? Suppose they get settled on steroids and other.
Yes, sir.
You would.
If the-
And if someone has grade 3, you will not re-challenge, even if they have had a short course of steroids and they settle down. Yes, Piyush, you can have a mic and someone help Piyush with the mic. Yes, Piyush.
Just wanted to ask, like a
Yes,
grade
you
3,
have to
I'm
ask
just
them.
giving a scenario, like a grade 3 pneumonitis, and that was about more than grade 2 pneumonitis post-radiation. And it settles, let's say, as you said, that within 12 weeks, the symptoms settle. But the radiological signs will not, probably. The symptoms settle within 12 weeks. Would you again re-challenge with Durvalumab?
Based on performance status and taking the clinical decision.
Performance status is improved. So
If it is less than, if it comes to grade 0 or 1, we can restart.
Okay, fine. So we'll go to the next part. This is quite interesting. We have Srinivas here. He can definitely take a comment from the house, but we will first talk about IMPT versus IMRT. And this was one of the large data set which I could find out in the literature. It is around 1400 patients. It's a JAMA publication of 2020. 1400 eligible patients. It's of course a retrospective, non-randomized, just a comparative effectiveness. 1400 patients. 1000 have received photon-based or IMRT and 390 have received proton. 390 proton-based CTRT is a good number and experience of the centers. Now, if you see the grade 3 adverse events, the primary endpoint of their analysis was adverse events, and that is what has been shown in the forest plots, that once the patient is on IMPT, the 90-day grade 3 adverse events are 11 versus 27%, almost double difference. It's more than a double difference. And even grade 2 adverse events is 74 versus 84, a 10% difference. But DFS and OS are actually, it's a retrospective analysis and this was not the primary endpoint, but we are not compromising on DFS OS as per these curves. And of course, there is a disproportionate, there is a 1000 patients on one arm and 300 patients on the other arm, 390 on the other arm. And this was the paper which was presented. And I think we have all heard to Srinivas. What I just want to bring to your focus is that we are definitely seeing these figures of PS2 as 7% versus 28%. But please keep it in mind that in this pie chart, the PS2 patients who have gone on IMRT are much more. If you see the pie chart above of IMPT versus down, that is the blue one which is above. And this is the IMPT and this is the IMRT. The PS2 is the red curve, and you can see there is a good number of patients of PS2 who have gone on IMRT versus IMPT. And with this, we have to interpret this paper with keeping this thing in mind. Okay, IMPT versus IMRT, stage 3, of course. Any experience of the, to be frank, we don't have proton, I don't have any experience.
No, sir, with proton
Dipal.
therapy.
Okay. Srinivas, that's why I said that I will take your first question to you. Both two, if you can take the experience and then particular scenario where you would like to, we all know the guidelines, it is not yet approved, that is fine. But Any particular scenario where you would really suggest or
So we are treating protons for stage 3 non-small cell lung cancer, unresectable ones, especially low primaries where achieving dose constraints is challenging. Also for N3 nodes, contralateral hilar nodes, bulky mediastinal nodes, these are the situations where we commonly use proton therapy. And we have seen that definitely the dose to the heart, dose to the cardiovascular structures, as well as the pulmonary lung V5, V10, V20 is significantly lower with IMPT compared to IMRT. And the tolerance, I cannot speak on the basis of 40 patients, but we can say that we have treated a number of patients. 2 of our patients have received Durvalumab adjuvant, and they are doing well. But I can't take anything from there. But the fact is that it seems to be feasible. It seems to be possible to do that. And we have noted the same thing that, it's a very anecdotal, but the hospitalizations, of course, this is a mixed bag of patients. The UPenn study, it's not just lung, it's head and neck, lung, and everything else. But definitely the unplanned hospitalizations as shown in this study, the delay in joining work and all those endpoints were basically assessed. We also believe that usually the acute toxicities are definitely low. The hematological toxicities are there definitely, but acute toxicities are low. Even hematological toxicities, we have seen that in elderly patients, in frail patients, hematological toxicities seem to be less. Based on our experience.
Concur that it reduces the toxicity.
Yes, it does.
Dipali, any comment from your side?
Yes, to just add into that, because this whatever studies are they are seeing the performance status, so that adjunct therapy can be added into that. So definitely with proton therapy, I guess continuation of Durvalumab will be much better than IMRT, but still it is not
the standard of care.
Yes.
Okay, fine. So that I will complete that sentence. The heavy heart, other radiation oncology is difficult. I will complete that sentence that it is. We wish that it is a standard of care and it is having less of financial toxicities, as we always talk about. We are left with 2 minutes. This paper I will just go in brief, and this is about nivolumab. I think we know this. This was a very few number of patients. Only thing was, which is special about this paper and has been included by the organizers, is that nivolumab was given concurrent with radiation, and just to see the feasibility, and the toxicity was manageable. But what is more happening in this field and interesting is these 2 abstracts. These are again from 2020 and 2022. This is these are not the phase 3 trials. These are phase 2 trials where atezolizumab has been combined with 1 cycle before and then 2 cycles with CTRT and then giving it for 1 year. And there is also pembrolizumab where it has been given 1 cycle as a neoadjuvant, then chemoradiation, and then pembrolizumab maintenance. The primary endpoints are response rates. And this is an ASCO 2022. If you see again, I said that 2 years, if you remember the 2-year PFS, OS is 64%, which was around, I think, similar in the Durvalumab arm, whereas in the adenocarcinoma it is 71%. So by adapting this strategy, what I want to say is that patients are really doing better. I am sorry, the 2-year OS is 64%, which was around, I think, 45% in the Durvalumab arm. And their PFS is also very good, and non-squamous are doing much better. There is definitely adding to a toxicity when we are adapting this strategy. So to the medical oncologist first, what do you think is the future? I mean, we have also discussed Nivo-EP consolidation and other trials and other which are coming up. Dipali, are you comfortable with this strategy of giving pembro chemo first 1 cycle, then CTRT, or atezo chemo and then CTRT and then consolidation?
So no experience with the pembro.
No experience, yes. Anyone from the house? We can have a quick comment. Actually, the time is less, so I had to rush through these 2-3 slides so that we can come to the...
Yes, it's a good strategy, doable strategy, but we have to look for the pneumonitis, like does it increase?
It was actually a significant pneumonitis is there. Grade 3 toxicities are 64%, and the more than 10% pneumonitis is happening in 6.3. So there is a significant pneumonitis as well as grade 3. I mean, grade 3 for toxicity 64-50% are too much. Even grade 3 pneumonitis was 3% in the Pacific, and here it is 8%. You had a comment, just a quick one, Mike Lil. Can someone give mic to Pew?
The future is either a fixed dose Durvalumab, a 3-weekly or 4-weekly regimen Durvalumab?
That we can do today also. I mean, Durvalumab we can go to 4 weekly.
So that was my question. So if the patient is borderline affordable, would you be comfortable using 3-weekly, 4-weekly, or a fixed dose Durvalumab rather than not giving Durvalumab at all?
I will need 2 more minutes. Yes. So Durvalumab fixed dose, you want to say, I mean a standard dose.
Stat dose or 3.
So you want to say low dose Durvalumab basically,
or a
Rajat?
4-weekly regimen rather than not giving at all if the patient is borderline affordable.
Okay, low dose Durvalumab. So he wants, he is not saying standard dose converting into 4 weekly, he is suggesting low dose Durvalumab. maybe.
So I am suggesting that I have a patient who is borderline
Got it,
affordable.
got it.
who's not
You want
able
to complete
take
a-
it, then how do you give it?
Got it, Rajat. Matlab, if you are not able to complete a year, you want to give it for 3 months, it's better to complete a year and give low dose. Low dose man in the house,
Yeah, nivolumab. That.
which you had shown. You had mentioned in your trial, in your talk that you can go with a abbreviated protocol rather than the dose.
But nivolumab would not give that support program, but Durvalumab will give. So
Okay, I got it, Rajat, but we can think of using abbreviated. Sorry, I will have to cut the discussion. We will have to take very quick comments from all the 4 panelists, and please be very quick because we have only 2 minutes and we have to cover these 5 questions. So for driver mutated metastatic NSCLC, Durva, yes or no?
KRAS yes, rest no.
Okay.
Yes, sir.
KRAS yes, rest no.
KRSS best.
Okay, very good. Would you continue Durva maintenance if you have grade 1 or grade 2 pneumonitis? Dipali?
Yes, sir.
Grade 1,
After
grade 2.
treating, yes, sir. After
Yes.
treating with steroids.
Unanimous, yes? Okay. Will you consider IMPT in any patients of yours with CTRT? Provided what Srinivas told us that they are frail, 75 years, they have large mass, they have bulky mediastinum, they have bulky nodes. Yes, no? Dipali? I'm
Yes,
not
sir, we
saying
can-
standard guidelines, it is will you consider?
Sir, yes, sir.
Others also agree, yes or no yet?
If no
Yes, we would
financial
like to
constraint, we
consider.
can
So
go.
Srinivas, they would like to consider IMPT. Any concerns regarding Durvalumab maintenance for patients undergoing IMPT-based CTRT? Srinivas gives IMPT CTRT, refers to us sitting at 4 different places in India. Durvalumab maintenance, yes, perfect. Unanimous, yes, you will like to consider Durvalumab consolidation post IMPT-based CTRT. Okay, and the last is difficult. I think I will stop this. What is the best way to combine IO with CTRT? We don't yet know. I will take this question. I think what Vijay mentioned that yes, you can give an abbreviated protocol rather than if you cannot give standard Durvalumab. I think there will be much more to it. We will have combinations such as atezolizumab and pembro coming into neoadjuvant as well as concurrent settings because already they have entered into the perioperative settings before surgery. So with this, yes, thank you for extending the time by 2 minutes. And can we have a round of applause for our experts? Thanks. And thanks once again to all the organizers for giving this opportunity. Thank you.
Thank you, Dr. Randeep,
Thank
for
you,
the
sir.
very
Thank you,
interesting
sir.
panel discussion. Next is case-based discussion on the optimal management of stage 3 unresectable non-small cell lung cancer. The moderator is Dr. Deepak Kopaga from Hyderabad. I invite all the panelists to come to the dais.
So, hi everybody. Thank the organizers for giving me this opportunity and Astra for allowing me to moderate this session. I think my discussion would be redundant after what Dr. Randeep sir has actually discussed. Actually, it's everything that I'm supposed to discuss over the next 30 odd minutes that I'm being given, but I would like to make it a little more interesting by having 2 cases which were very difficult for us to manage. Most cases are a little, we have a straightforward protocol to manage these patients, but here I would like to discuss 2 cases which were real challenge and they started posing challenge at every step we tried to manage this patient. So I would like to invite the panelists, and it would be an open discussion on how everybody here in the hall and my panelists would be handling these patients. So Dr. Akhil Kapoor, would you be joining us? Dr. Anil, Dr. Tarachand Gupta, Dr. Rajat, Dr. Arun Chandrasekharan, Dr. Raj Purohit, and Dr. Satish Pawar, sir. Dr. Sumit and Dr. Mistry. So it will be a very cordial discussion. For all practical purposes, these patients have all money on earth and they can afford everything, and we have all the expertise to manage these patients. So I think financial constraints wouldn't be discussed. So yeah, so here are my panelists. So they are really tricky questions, but this is where the questions that the patient posed to us when he walked into our OPD. And yeah, get ready for some bouncers. And I want it to be interesting. I would like to have all the panelists participate and also the audience participate. So I'll start with the first case. This was a 34-year-old. He's a pharma executive who's a non-smoker, presented with hoarseness of voice, cough on drinking water. Chest X-ray was done at an outside hospital, which revealed a left upper lobe mass with left hilar region opacities. A CT chest was followed by a CT chest which revealed well-defined dense nodular lesions in the apical segment of the left upper lobe, measuring 26 into 16 millimeters, and a well-defined prevascular and hilar lymph node, which is largest 54 into 29 millimeters. So pretty big prevascular station 5-6 node and hilar lymph nodes with a small lung lesion. So just for so this was the image, the CT scan done outside. So these are the lymph nodes he had. This was one lesion he had in the apical segment of the left upper lobe, and this was the hilar lymph node the patient had. The CT sections. So just for us to discuss, I thought this would be more easy. So this is the lesion here. This is the station 5-6 node. This is the hilar lymph node the patient had. So I think it's clear, right? I'll move with the next slide. Sorry. So Dr. Akhil, next plan. What would you consider here in this patient?
So we have not got a biopsy, correct?
No. So this is how we presented, and these were the investigations the patient came with.
So it seems that the disease is close by. If it's feasible, bronchoscopic guided biopsy can be taken.
Okay.
Or else, if a radiologist comfortable in CT guided biopsy, that can also be done.
It's very close, yeah.
It seems that bronchoscopic biopsy will be better in this.
Dr. Anil?
Yes, same here. The biopsy should be done. Either CT guided or bronchoscopic biopsy.
Bronchoscopy, yeah.
And after confirmation of the histology or the diagnosis, then we should.
EBUS, you have a hilar lymph node. EBUS, would you plan if you're doing a bronch?
Yes, in EBUS, because as I understand, there is no surgery here.
As Satish is a surgeon here. Yeah.
But he can take that question if we think that the patient is suitable for surgery, then obviously yes.
So the DD outside when he was presenting, 34-year-old young, he had some fever on and off. So they were doubtful whether TB versus malignancy was the doubt.
Yeah. So after the diagnosis, obviously.
Yeah.
At that age, especially, you should have that in mind that if a patient comes to an oncologist, that you should also remember in our country that predominantly there can be sarcoids, there can be tuberculosis. So you should take all these with a pinch of salt, primary with a staging of a lymph node.
Yep.
That's more important.
So as told by Dr. Akhil and Dr. Anil, so the patient had a bronch done, extrinsic compression and mucosal irregularity of the LUL apico-posterior segment. EBUS, there was segment 10 left enlarged node. Multiple TBNA passes were done and adequate lymphoid sampling was there. So perfect investigation so far. And this is where it started. So the bronchial biopsy was very clear. It was IHC was done, small specimen, TTF1 positive, P40 negative. It was favoring adenocarcinoma with lymphatic spread. So this is where it all started. The station 10L was reactive lymphoid infiltrate, and you could all see the extent of lymph nodes, very bulky necrotic lymph nodes, but on EBUS it was negative. So the EBUS TBNA station 10L was only sample, 5-6 not done. So yeah. So yeah, what next, Dr. Tara Chand?
I think we can do a PET scan to see the avidity if the FNS is negative, and the PET scan is showing the avidity, then we can go with the mediastinoscopy.
Wonderful. Ajit?
So yeah, definitely staging workup should be done with PET scan and MRI brain. So if the PET scan, it favors that the avidity is similar to the chest mass, then probably we'll start with the treatment itself.
So the node is avid, the primary is avid, and the hilar lymph node is also avid actually. So no other metastasis anywhere else. So this is the report, and no systemic disease anywhere else.
So I'll start with if there is no systemic disease, I'll start with the standard CTRT.
You would still go with CDAD because your node is still not positive. So,
yeah, but it looks like the other approach will be to start with NACT first, followed by assessment, but I don't think that any other possibility should be there. If the sampling was adequate, then I don't understand.
It was not actually adequate. They were only doing the 10L node. The 10L node sampling was adequate, but they've not done a proper staging
mediastinal staging, complete mediastinal staging and MRI brain are pending.
I would be comfortable with the PET CT report after discussion with the nuclear medicine guy. I can start the patient on the the standard CTRT.
Okay.
See, I have a difference.
Please, doctor.
I would go for a repeat because we've had these issues where the first biopsy is negative because I would definitely want to confirm it. We have had surprises where, the node turned out to be something different. In this case, as Dr. Rajat said, most likely it's going to be malignancy, but something that's 2 centimeter or 1.5 centimeter, doing a repeat EBUS would definitely add to, the data which is there. So I would do a repeat biopsy in this case.
I will disagree with the fact that, see, for example, if the patient is diagnosed case of adenocarcinoma here, we have a left upper lobe primary T1 lesion, maybe T1B or T1C, and you have a prevascular nodal mass, which is approximately more than 3 centimeter, 5 centimeter. So if you want to stage the disease, then it's at CT1, CN2, and CM0 disease. So it's already stage 3A/stage 3B. So we have made our staging as far as this workup is done. We just need to decide whether the surgery is feasible or not. If the surgeon says that the hilar node or the prevascular node is unresectable, I don't think so any more further point in going ahead with the EBUS, so repeat EBUS or the mediastinoscopy. If the patient comes to the radiation oncologist, we would be happy to consider the hilar node as a positive because it is very avid as compared to the primary and the node. Then,
And for practical purposes, the patient will probably change the institute if you ask the patient.
Agreed. So no practical issues for this discussion. So anything else from the audience? Anything else?
Front surgery is possible in bulky N2 in the 5.5 centimeter. It is possible in bulky N2.
So anything else, sir?
Front surgery.
Anything? I mean, invasive mediastinal staging. Would people consider invasive mediastinal staging, or would people still go for, based on the PET, go for treatment? Dr. Vijay, sir. You would still go with invasive staging?
Available, everybody will confirm after PET scan also they will ask for a mediastinoscopy or a EBUS guided FNAC, confirm it and then only go ahead with the treatment, because if the patient is N2 bulky or N3, they may not recommend surgery at all. They will be out of the trial automatically.
Yeah, sir wants to,
Hello? Yeah. The fundamental thing is if the primary is resectable and in the surgeon's opinion, the nodes can also be taken out, the attempt should go towards curative intent treatment, and that would involve neoadjuvant chemo. Some centers would even do neoadjuvant chemo radiation. So if you have the primary is clearly resectable, a 10L node is never a problem for a surgeon. Some mediastinal disease is also not a problem. So you could easily downstage this with NACT. You could then see the status and take a call on surgery or not. But this patient should not go directly towards a non-curative intent treatment.
Yeah, agreed. So the patient presented with RL and palsy, his complaints were vocal cord palsy.
CTRT is not a curative treatment. Surgery is not the only curative treatment option. So if the patient has we are increased risk of the post-op mortality because of the bulky disease, we should consider this the option also. Because not the surgery is always not the curative option.
No, that is fine, but the surgeon and the anesthetist will take an ultimate call whether the patient is fit for that. That's an entirely medical operability and resectability are two different issues, and they need not factor in for such things.
Yeah, so I think that was the point of discussion. But yeah, we still try to be curative in this patient. And again, this emphasizes the point of discussion here, that is, it's a team approach, and we essentially need all three of them. And if, even the data says there is significant improvement in survival when there is a MDT approach that is followed in lung cancer management. Agreed. I mean, yeah, eventually it is pulmonologist, anesthetist, everybody is essential. And any further investigations, again, I think that brings back to the point that station 5-6 are very, it's impractical to sample station 5-6 on an EBUS. And the patient TEL-L was negative, though there was adequate lymphoid sampling. So sampling mediastinum was the point. So Dr. Tarachand, no. Sampling the mediastinum, yes, no.
Yes, if the initially FNAC is negative, and then PET is positive, then we should do the sampling if it is N2 positive or not.
Rajat is no. Practically, patient wouldn't stay with you. So
see, it's not about staying. I would discuss with my surgeon. See, if my surgeon is planning to, consider this patient for surgery, then definitely yes.
Yeah.
But if the surgeon is not comfortable, then why do you want it?
Yeah, my surgeon, Dr. Satish.
At this age, with good pulmonary function test, I would at least put in a scope and see what it is.
Yeah.
Okay. So especially on left-sided tumors, where we don't really do extended e-buses, so it's always better you put a thoracoscope and see what that node is, whether it is resectable or not.
So we did a VAMLA for this patient, and this is what even the ESMO and the ESTS 2014 guidelines and the 2020 ESMO guidelines say, that if your EBUS is negative and there's a strong clinical suspicion, it's always better to do a video-assisted mediastinoscopy. And we did a VAMLA biopsy and it has come positive. I think, yeah, that makes point what Dr. Rajat has told. Clinically, it looks positive, but again, it's always better to establish it's a 34-year-old young patient where the decision of treatment of surgery or neoadjuvant treatment or chemoradiation would really be there. So it was a bulky mediastinal lymph node. So further management, Dr. Arun.
So the MRI is also been...
MRI brain is negative, yeah.
Is negative.
Yeah.
So you have a stage 3, I would take the opinion of the surgeon. It's a bulky mediastinal node.
It's
so
5 centimeter.
5 centimeter. Yeah. Would the patient be ever, considered for surgery based on that, tumor board decision?
Yeah.
If I feel it's unlikely here, but if it's unlikely, then I would consider doing on the biopsy. We have not done the the EGFR driver mutations.
No, we've not.
So I would, send that once I get the first report, send that off, discuss with the surgeon. If it is resectable, then obviously something like neoadjuvant followed by reassessment. Unresectable, I would go for CTRT and have a look at the final driver mutation reports as well.
Dr. Akhil, ma'am, please. Sorry,
Yeah, same. So I would like to do EGFR mutation testing.
Upfront, would that... I'm
Yes.
asking the next step that you would be doing in this patient. Upfront, you would be sending for mutation analysis.
Yes.
Agreed. Okay. So, Dr. Akhil, anything else that you would like to do in this case? Or...
No, it's fine that if we are planning chemo radiation as you are highlighting, definitely getting a EGFR, ALK and PD-L1, these 3 tests we minimum do even in patients to decide.
So EGFR, ALK?
ALK and PD-L1.
EGFR, ALK and PD-L1, yeah, agree. So you're... Yeah. So I would like to... Wait, can I answer? No, I'm again, the essential... even the Checkmate 816, which has gotten approval, was not used for conversion surgeries. It was patients who were operable de novo. I wouldn't be really keen. We had this discussion. The data was out. This was probably 3 months back. We started this treatment. We had this discussion in our tumor board, but we decided to go with chemoradiation. Considering the extent of... we still think it was a snap of where the patient was evolving. We are sure that with a very small primary with so many metastases is eventually going to develop systemic disease.
I agree with you.
So,
Checkmate 816 operable, but Nadeem had patients like this.
like this, yeah, agreed. It had the 3
N2s in
yeah,
there,
3Bs,
so
yeah.
That's one thing which we can consider in this.
Nadeem showed really good results, extraordinary results.
N2 was there, yeah.
Most
N2 the NADM 2, yeah. Yeah.
Looks like inoperable.
Yeah.
So the most important point is the surgeon.
Yeah.
If surgeon feels like, again the Rajat question was whether we are doing GSL sampling or not.
So,
it is again the surgeon's call.
I think the surgeon who's done the surgery is here, so he'll tell what was his intraoperative findings when he's...
So that's what,
yeah.
especially in left-sided tumors, prevascular node, or sitting in that AP window, if it is badly stuck to the vessels, then I would be straight away said, I would better not do surgery in these cases because leaving behind microscopic disease doesn't have any meaning.
So, Dr. Anil...
I wanted to ask
please,
you,
please.
the patient complained of hoarseness of voice.
Yeah, so there is
And the
RLN
left vocal
involvement
cord
already.
palsy, and I assume that there were some changes in the lung also. So I assume that the left hoarseness of voice
is because of the RLN palsy, because the node is...
AP window.
Yeah.
Other points are after the chemotherapy or upfront? That is the question.
If I have answers upfront, that would be more useful because just doing a diagnostic thoracoscopy and a biopsy will not cost patient much.
But again the question was that surgeon feels that it is inoperable.
Inoperable.
I am not operate this patient.
Yeah.
But instead of chemo radiation, if we start chemo immuno,
Yeah.
and then he will going to operate after 4 cycles or 6 cycles rather than chemo radiation.
Yeah, so we had all those discussions.
Sir,
and
other
that-
points are everyone is sending EGFR alcohol. Suppose it came EGFR exon 19 deletion positive.
So I think we'll discuss that. I think we just started with chemoradiation. I will be there. I will come to that point. Yeah, no, I will come to that point. So that's where we are heading. But yeah, I think there's a lot of interaction. But yeah, that's really good because the options that we have now is the big problem that we eventually encounter, and the tumor boards are getting more
Whenever we are
interesting.
sending, we should be knowing what will be the
Because see, the
further
point is
action.
he's there now with me. I send an NGS today. It's a 3-week turnaround time at the center where I work, and that's I'm handicapped for that time. I mean, for this extensive disease, I cannot wait for that long because I've already done a surgery. So that's the reason. 7 days is still a big time with that node is what we were worried. But again, I mean, treatment के लिए तो ज़रूरी है. Yeah. Okay, so I'll come back to the case here. A chemo drug of choice, Dr. Anil.
I'll use the platinum doublet, but I'll leave it to the medical oncologist.
Okay.
Randomized trial ongoing at both TMH Varanasi and Mumbai. Paclitaxel versus topo will enroll patients.
Okay, so this patient was on Cisito. Considering his age, we started him on Cisito. He was doing well. So yeah, this brings me to the next question. Further investigations completed chemo. So while he's on chemo radiation, how many of you in the panel would send this patient for PDL1 levels? So PDL1, all would be doing a PDL1 here. Okay. Okay, yeah. PDL1 is done. Okay. NGS? Okay. So the PDL1 comes as 80%. So I don't do PDL1 levels because I raised my hand even before that. Irrespective of PDL1 levels, I start patients on Durvalumab. But again, PDL1 80%, good enough. Completed chemoradiation. Within 2 weeks, he was fit. Didn't have any pneumonitis. CT was done just before we started him on this CT thorax. The primary and the node has significant response. Good to go.
Just one question here. Is your treatment dependent on PDL1?
Yeah.
Why are you doing it?
So see, what I learned is that PDL1 and histology, decides you how do you counsel the patient. So I have a patient on CTRT who has a PDL1 score of 95%. He's sarcomatoid histology and he's mutation negative. So you want to treat these patients. You are desperate to treat these patients. Yeah. So I know it will not change our treatment plan, but how you counsel the patient, how and what is the prognosis. So it will definitely help.
Agreed.
So we have data that if the PDL1 score is less than 1, it may not be that beneficial, but I'll still give if it is possible. But how do you counsel the patient? That depends on the PDL1 report, and that is very important and should be done.
Abhi, now you have this patient with this PDL1, very good response post chemo radiation. 80% PDL1, non-smoker.
Driver mutations?
Okay, good question. Next. Yeah, Dr. Akhil.
Yes, as I told, EGFR.
So this is irrelevant. Again, that's the whole point I was trying to make. So dose again. I'll come back to this thing. And dose, like Rajat was saying, how many of you use the 1500 mg 4-weekly dose? Anyone in the audience? The 4-weekly regimen of Durva? Nobody. Still, people use a 2-weekly regimen. Even I use a 2-weekly regimen. It's less costly.
Feasible to use. We use 2 weekly, but otherwise.
Yeah. So molecular analysis, the entire panel would agree on the molecular analysis, I believe. The audience also molecular analysis. Irrespective of the PDL1 levels, the molecular analysis is still important for us to move forward. Yeah. Agreed. Yeah. So this is what has come as. It's not EGFR. It's ALK. But again, the point remains where it is. Now would you give with the PDL1 80%?
So I think you have to keep the patient on observation with a big heart.
Yeah. This patient, from the moment he's walked into our OPD, he's throwing us surprises. It's pleasant in a way, but yeah, this is where we are. So, adjuvant Durva in this patient? A consolidation Durva, sorry. No. No, I wouldn't be following Pacific blindly. It's eventually clinical discretion that plays in. But
if you're following Pacific, you have to follow the way it was.
Yeah.
You did not discriminate ALK or EGFR. These things are after that, and now if the patient is being recruited into a trial, this will be an exclusion criteria.
We had the Durva phase 4 trial, but ALK was an exclusion criteria even in the trial. So he was not eligible for that. Navneet sir, your opinion, ALK positive, PDL1 80%.
very clear and strong opinions on this. There is data from analysis, real world settings, Stanford people have published, other people have published. EGFR or ALK positive do not benefit from the Pacific plan. So ALK positive, do not look at the PD-L1.
Yeah.
Do not give immunotherapy.
So that brings me to this question. He has a very small primary. He has extensive, very large, bulky nodes. I know he's going to relapse systemically. MRI brain for now, fortunately, is negative. Adjuvant ALK inhibitors, no adjuvant ALK inhibitors. Consolidation with ALK inhibitors. Because
My temptation still be for a very young patient with a resectable primary, try and look what is the status of the nodal disease post CTRT. At any point, if you have a window of opportunity to do a surgical resection, which means an R0 resection, that should be the aim. It can mean the whole difference for this young person.
Yeah.
So even if you're tempted to use an ALK inhibitor off-label, if it makes a difference in his outcome, I would do that.
So wonderful. I think that comes to the end of the first case. Now, the second case is a typical 76-year-old smoker. With a big heart, I'm waiting, sir. Seriously, that's what I'm doing. I counseled him regarding electrolyte.
Waiting to progress.
Waiting to progress. Eventually, it's going to happen. Deep in my heart, I don't want him to progress. But yeah, again, that brings me to the next case.
So what will be the panel's discussion on whether they will give adjuvant ALK inhibitor therapy or not?
Yeah, probably that's a very good question.
In this case, if the response is complete response, no.
Complete response, yeah.
80%, I would still give, the young patient, it's but personal opinion, I would give maybe for 1 year, and as sir said, repeat scan shows dramatic response to the point where it can be operable, or SBRT is an option, I would consider.
Which ALK, not for 2 years? Which ALK inhibitor would you give?
Depending on his pockets, if he's affordable, alectinib is the first choice. Not affordable, ceritinib. But I would give.
It hasn't shown any benefit, as per I think, in adjuvant settings.
No, I don't know about no benefit. The trial is still ongoing, right?
Yeah.
So based on the trial, should we take a decision in normal patients or not? When the trial is still going on.
So
we
as
are
I
not
said, sir,
putting
this
the
is
patient in a trial.
personal opinion. I would give the opinion to him. I would tell the patient to decide. This is what we are doing.
I think we'll go to the next case. We can always discuss. I have only 2 minutes.
So that's why we take signed consent for
this
oral
case is even
chemo now.
difficult. This case is even difficult. Please, I want all your opinions on how to manage the next case. He's a 76-year-old with...
Just 4 words.
Yes, sir.
Absence of evidence is not absence of benefit.
Yeah.
So if we go for the gefitinib, when it was used in adjuvant setting, in EGFR positive, there was a PFS benefit of near about 15 months, but OS does not turn out to be.
Yep.
So in this osimertinib, there comes out to be a PFS benefit. So it doesn't mean that we can use alectinib or any TKI in this patient also. So we failed gefitinib, we shifted on osimertinib, yes. So how to take a decision whether alectinib or crizotinib, yes or no?
I think that's food for thought, but the next case, please. We'll come back to the panel discussion, but there were wonderful points that are being made here.
Post CTRT situation is very different.
He has a complete response on scan.
Yes, still, even if partial response, still we need to be very cautious.
Yeah, I agree.
Advising TKI.
Yeah, true.
And I think there was some retrospective data which suggested there is a high toxicity if after CTRT we give ALK inhibitors.
Yeah. Again, these are all data which are weighed when we take a decision in practice, but we really I'm really not having the energies to push him for alectinib right now. I'm holding on and waiting for him to, I'm monitoring him closely. So this is a 76-year-old with multiple comorbidities.
Yeah, just 1 minute, huh, Babu?
Sorry?
1 minute has got over, so we'll discuss this on lunch break.
Okay, fine.
Or just wanted to show maybe quick, within 2 minutes.
So this is what
and
it is.
now the only panel is this.
So patient has a station 7 lymph node. Okay, he has a lung mass with a station 7 lymph node. It is T3N1 with some pleural lesions. So pleural lesions were suspicious. So we planned thoracoscopic biopsy. It was on thoracoscopy, there were no lesions present. Again, I think it's very difficult without the context being placed. So, okay then, thank you all. Thank you.
I think you can just briefly tell what you did.
So, okay, so this is a patient who is T3N1 clinically. We've done PET CT. There were some pleural nodules which were indeterminate, which were clinically suspicious. So, and it was just single station N2. The whole point I would would like to discuss this case is, would this patient be fit for an upfront surgery? Single station N2 with suspicious pleural nodules. Eventually a thoracoscopy was required. So in the same sitting, we were planning for surgery in this case. So any takers for upfront surgery, single station N2. Okay.
Fluoroscopic biopsy was done?
Thoracoscopy was done, negative, nothing. Those lesions were indeterminate. Okay, so the patient was planned for VATS, lobectomy, and mediastinal lymph node dissection, but post single lung ventilation, the patient had hypoxia, the procedure was aborted. Again, the patient was received chemoradiation. On initial CT scan, the lesion size increased. Post 8 weeks, he's completed his treatment. PET CT showed there was an increased necrosis. The necrotic component increased significantly. That was the reason the size on HRCT was looking big. Is this a point where would you consider Durvalumab? He was KRAS mutant. EGF PD-L1 levels were somewhere around 30% in this patient. KRAS mutant. Durvalumab, no Durvalumab. I'll start with Rajat.
So can you repeat the NGS profile, sorry?
KRAS mutant, PD-L1 was 30%.
And the rest were negative.
Sorry?
Yes. And yes, I'll give.
Okay. The size increased, but it was the necrotic component that increased. Would that make a difference in practice?
So not practically. See, clinical symptoms, you need to correlate with the symptoms also.
Yeah. So the next, please. Your opinion, adjuvant consolidation Durvalumab, yes, no?
Yes.
Yes. Dr. Anu? Okay.
Necrosis is, this is what we commonly see.
Yeah.
Necrosis component increasing, size increasing, but that doesn't deter as a...
Okay. So thank you all. Sorry I had to rush, but thank you. It was really wonderful discussion. Thank you everybody.